In the United States, radiographic technique is usually managed through fixed kV systems. There are other systems available, but the prevalent fixed kV system ensures appropriate penetration and optimum contrast. Understand that even though the fixed kV system is prevalent, every individual X-ray unit requires its own specific technique chart to be generated based on average human dimensions. It is up to the technologist to be aware of this and to make the necessary adjustments for smaller and larger patients, primarily using the 30% rule of mass. In some extreme cases, such as morbid obesity, kV may need to be adjusted by 8% or even by as much as 15%. Optimal exposure is necessary for accurate diagnosis and adherence to the Elara principles. Underexposure results in increased quantum model, reduces image quality, and may impede diagnosis. Overexposure reduces quantum model, improving image quality, but will also increase the patient's dose. The fixed kV chart benchmarks the technique settings needed for various body sizes. The use of calipers allows the technologist to choose the appropriate technique based on the measurement of the part of interest. The calipers are positioned to measure the thickness of the body part based on the direction in which the central ray is projected. We are now going to view a short video emphasizing both improper and proper techniques and some of the possible outcomes. Now, as you can see, We did kind of mock what might actually happen, but in reality, if we don't do our jobs correctly, there will be cases where we have underexposures and overexposures. In these images here, you can see the image on the left is properly exposed, and you can also see all the anatomy of interest. Whereas in the image on the right, the image is overexposed and there is too much density, and information regarding the anatomy of interest and possible pathology is lost. When penetrating body tissue, ionizing radiation produces biological damage primarily by ejecting electrons from the atoms composing the tissue. By overexposing or underexposing and not adhering to the principles of OLARA, we are increasing the probability of creating radiation damage at atomic, molecular, somatic, and genetic levels. Here again we have two images. The one on the left is properly exposed and shows the proper anatomy of interest, and if there happens to be any pathology, a radiologist should be able to see it. The image on the right, however, is underexposed, and it's all washed out. The patient is a very large patient, and the technique used was used for an average patient, and no adjustments were made. And as a result, you can't really properly see any anatomy of interest or pathology, and the image will have to be redone. Because of the evidently greater attenuation in larger patients, when using techniques designated for average dimension patients, the technical exposure factors will need to be increased. We would most probably increase mass for moderately larger patients, but for more disparately large patients, most of the radiation will be absorbed in the subcutaneous fat, which is the main reason our technique must be adjusted accordingly, and an increase in the kV may be mandated. So what have we learned? We use fixed kV systems for optimum contrast and resolution. There's an unfortunate fact to consider that as the size of the patient increases, the attenuation will also increase unless there is a factorial change. To aid in setting proper technique, we use calipers to measure patient thickness by placing calipers over the part of interest and measuring thickness in the same direction the central ray is directed. We also always adhere to the OLARA principles, keeping the dose as low as possible for the patient and the technologist. We do this by using a fixed kV system, which is good for an average person, but the adjustments for a smaller and larger patient varies by the degree of size differences. First, we would try to adjust our mass by either 30% or 50%, and in extreme cases, we may have to adjust the kV by 8% or 15%. With overexposure or underexposure, we're going to lose some anatomy of interest, some pathology, and we're going to have an increase in patient dose. The proper part penetration will allow for a decrease in patient dose and will decrease attenuation, but keep in mind an increase in kV will also increase scatter radiation.